My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Brigham and Women's Cancer Center. As our management of the breast and axillary lymph nodes has evolved over the last several decades, we've really moved towards a less is more approach. And we've been able to do this because of advances and improvements across the multidisciplinary management of our disease. So widespread screening mammography has allowed us to identify tumors at much smaller sizes. We are much less likely to see women presenting with advanced or inoperable disease than we were 2 or 3 decades ago. In women who do present with advanced disease, our systemic therapy treatment options are so much more vast and so much more effective, and so we're able to downstage and really optimize our local regional management strategies. So we've been able to dial back on the extent of surgery, both in the breast and in the axilla over time, due to many of these advances and all working together in multidisciplinary teams. When I was in training, performing a level 3 lymph node dissection was not uncommon. We weren't using nearly as much neoadjuvant chemotherapy then, and patients were presenting with more advanced disease. But as we've seen, again, the trend towards presentations with earlier stage disease and the use of preoperative therapy in women who present with advanced disease, this really has limited the number of times where level 3 dissection is necessary. So the standard lymph node dissection today, whether in the upfront surgery setting or after pre-op therapy, is typically limited to level 1 and 2 of the axilla. But again, in women who have negative sentinel lymph nodes biopsies, we're not doing axillary lymph node dissections in them at all, and we're really identifying opportunities to omit lymph node dissection even in women with lower volume disease in the sentinel nodes, 1 or 2 nodes. So really the likelihood of performing a full lymph node dissection and the likelihood of performing a level 3 axillary lymph node dissection in today's breast cancer patient is really quite uncommon. Now, women who present with inflammatory breast cancer or women who present with extensive adenopathy on preoperative imaging, those are women that when you take them to the operating room, presumably after their preoperative therapy, that you do want to really fully assess the axilla on your intraoperative evaluation. We always teach our trainees to palpate level 3 of the axilla. If there's anything palpable in level 3, you will want to perform a level 3 lymph node dissection. But if there is no palpable disease there, then we tend to really focus on level 1 and level 2, knowing that level 3 of the axilla will be included in regional nodal irradiation, and patients, again, presenting with inflammatory disease or locally advanced extensive node positive disease, we know we'll all be getting regional nodal irradiation after surgical management. And so if level 3 feels normal, no palpable adenopathy, then there's really limited indications for doing a level 3 dissection, again, in today's breast cancer population. It is still obviously important for us to teach our trainees how to access level 3 if needed, how to identify a disease there. And also we need to remember the importance of the Rotter's lymph nodes. Rotter's space is between the pectoralis major and pectoralis minor muscles. We teach our trainees to palpate that area, and certainly any nodularity in that area or any evidence of disease, we want to remove those lymph nodes as well during the lymph node dissection. But the use of lymph node dissection has really decreased and evolved as we have had a better understanding really of the importance of limited volume disease, the opportunity to omit lymph node dissection in patients that only have limited volume disease, and the opportunity to downstage and eradicate nodal disease even in women who start out as being lymph node positive. So the performance of axillary lymph node dissections today is much less common than used to be. And even when we are performing lymph node dissections today, we're really rarely performing level 3 lymph node dissections, reserving those procedures really for patients with really advanced disease who do not have a good response to preoperative therapy.